Thank you so much. And thank you for allowing me to moderate even remotely. Welcome back. My name is Aviva Goldberg. I'm a pediatric transplant nephrologist and ethicist here in Winnipeg, Manitoba. And my plan was to be there in person today, but due to family reasons, I'm home here in Winnipeg, which is, of course, Treaty 1 territory and the birthplace of the Red River Métis Nation, among many other wonderful things, and an area where I'm very privileged to live, work, and play. We are going to begin the first session of this symposium entitled Equity in Care for Pediatric Transplant Patients and Families. There will be a Q&A period at the end of the two presentations, and Dr. Laurie West has very graciously agreed to step in to moderate that part for me. But our first speaker this morning is Dr. Carolyn Tait, whose presentation is entitled Social Disparities in Transplantation. Dr. Tait will be well known to many of you. She is a medical anthropologist with research interests in Indigenous health and social justice. She earned her MA at the University of California, Berkeley, her PhD at McGill University, and is a member of the Métis Nation, Saskatchewan, and grew up in a small Métis community in central Saskatchewan. With Dr. Michael Moser, Dr. Tait established the Saskatchewan First Nation and Métis Organ Donation and Transplantation Network. She has joined the Faculty of Social Work at the Cummings School of Medicine, Department of Community Health Sciences at the University of Calgary as of January 2023, and is a Canada Research Chair in Indigenous Health, Equity, Inclusion, and CDTRP's Indigenous Platform Lead. Welcome, Dr. Tait.
So good morning, everyone. I'm very happy to be here, and thank you for the invitation. I live on Treaty 6 territory, and the homeland of the Métis. So I live up in the bush, and I spent last week skiing for the first few days and ran into a timber wolf, and I run into elk all the time, and so it's very fun to be among people because I spend so much time alone. But I also want to bring to you today a very wonderful gift, and that's the work of Laird Goulet, a Métis artist that I know well in PA, Prince Albert, and so his artwork is through this. And I also want to hug everybody in this room. I am so happy with transplant people this week because a very good friend of mine had a lung transplant a couple days ago, and she's doing well. And so I just want to hug all of you guys. So this is where I grew up. It's weird to see an Indigenous person with blonde hair and blue eyes, but we're not as weird as you think. These are pictures of my family, and my son is a Tunisian Métis who lives in Montreal now. But the far picture, I think many of you have seen it, the picture of my dad and my brother, and I love that picture because it really shows, I think, kind of the Métis people and our diversity. But so I was asked to speak about social disadvantage, and I'm a medical anthropologist. So this is really where I spend a lot of my life and research. And so social disadvantage really refers to those determinants of health. And even within anthropology, we talk about syndemics and this interaction between illnesses that people have interacting with the social, cultural, economic context in which they live, including geography, but also sexual orientation and disability. So the question of how does social disadvantage impact a patient's transplant journey? And so I'm going to turn to a study that was recently came out. It's a scoping review done by Lynn and colleagues, and some of you probably maybe were even on the paper. And so this was an interesting scoping review that looked at Indigenous children in Canada, the United States, New Zealand, and Australia. And I'll focus on Indigenous. That's mostly what I know, but we see from American studies that there's huge disadvantages when we look across different ethnic and cultural groups in the United States, particularly around African American and Hispanic children in terms of access to transplant medicine. And what that means and what are the factors But in this case, the access is defined as the ability to use timely and available healthcare services to achieve the best health outcomes, including being placed on the solid organ transplant wait list, time to solid organ transplant, and access to living or deceased transplantation. And so when I read this study, nothing about it, it's a very important study because no one has done this before, but the outcomes were nothing that really would be surprising to anyone that works in Indigenous health. That you see that there's, of course, greater challenges for Indigenous patients pre and post-transplant, geographical remoteness, financial stressors, family considerations, and the need for urban relocation for our northern people. So many of our northern people, and if you look at Alberta and Saskatchewan, for example, 85% of the people who live in the north here are Indigenous. That's the highest percentage per capita, even compared to the far north. So we have these large concentrations of Indigenous people. And that the authors point out that there's an absence of meaningful discussion about the impacts of historical and sociocultural determinants, including settler colonialism, intergenerational trauma, cultural bias, and institutional racism. So, but what does that really mean when that's put in front of us, right? So I want you to go on a little journey with me, if you will, and we want to look at transplant medicine and the ways in which we talk about ethical and moral language and the emphasis that all Canadians have equal access to transplant medicine despite social disparities. So you will hear this often, that you have equal access. But what does equal access really mean in the context of the lived realities of patients and families? So even I admittedly sat through the last presentation and I nodded my head like I knew what was going on. I didn't know what was going on, but I was really interested in the types of questions that in a clinical trial like that, where do my questions fit into a trial like that? And should they fit in, right? And do we need more of a lens that looks at patient experience? So does equal access include addressing the social disparities experienced by patients and families if this is not what the mandate of transplant programs or research programs are? So who is responsible? So within the context of even the scoping review and the studies that were looked at, there's no responsibility really about whose responsibility is it for social disparities. So transplant medicine, I know you're loving Laird's artwork, right? He's just amazing, like how one person can have all of that inside of them when someone like me has none of that. But so transplant medicine is very urban centric, right? So including the expectations that patients travel to attend clinics and hospitals despite where they live. So really in transplant medicine, all of those questions, I'm like a dum-dum without my 24-year-old son. It's like, I'm not sure what happened. We might have lost the okay, so so mostly what we have here, and as I sat on the national committee looking at organ donation and transplantation, it's very urban centric. It's very hospital based, very clinical based, and so it puts a lot of burden on the patients to respond to the needs of the hospital, the transplant program. So patients are responding to your needs essentially. And this is particularly hard for people living in northern, remote, and rural areas. And so I'm going to go, Arthur Kleinman was a mentor of mine way back in the 90s when I had the privilege of being a visiting fellow at Harvard and working with Dr. Kleinman. And so he suggests there's a failure to take into account the local worlds in which patients and practitioners live, worlds that involve unjust distributions of power, entitlement, and resources. And he really pushes us to look at what is the patient experience in relation to what we are up to in terms of the clinical and healthcare delivery that we provide. And he points out to us that most of what happens for patients does not happen in your clinics or in your hospital settings. Most happens outside of that. And that's the journey I want us to go on. And so while transplant programs and supporting agencies seek to provide the best patient care and achieve optimal outcomes, we cannot forget that for patients and family, illness experiences are largely interpreted and responded to in the context of the family. So the mundane cultural settings of illness and care where local social processes are so greatly influential. So what does that mean? And so in the case, going back to the scoping review, we really have that pointed out where healthcare disparities. So in our Indigenous population, delayed diagnosis is something that is common. Limited or no access to care. The tyranny of geography, so having to relocate, family breakup, and social and economic disadvantage. So the human and financial costs of relocating, attending appointments, aftercare, all of those factors come into the decision-making that happen within those local worlds. And so I'm going to give you an example that came up. So we ran a think tank of Indigenous people in Saskatchewan, as many of you know, for about 3 years. And we had a presenter come from the far north. And this was a relative of this family. And her presentation was about a young child who had had a heart transplant from the far north. So the family went through everything that you would do, coming into the urban center, working through all of the different steps for that transplant. And eventually the child did have a transplant. So there were things that influenced the family's decision. And then there were lots of financial costs. There was worry, there was the family being apart during the whole time, but the child did get the transplant. So it was successful, so successful. And then they had to have their child adopted by somebody else so that the child could stay in the urban center and be raised in the urban center, because where they lived, they couldn't provide the types of care the child needed to survive. So even though the clinical care was successful and the patient's life saved, this didn't mean that everything worked out. So if you can imagine, let me flip you on your heads and say that your child needed some type of emergency care, and your only option for them to be healthy is to move to the far, far North Arctic, relocate your family to the far north. Establish yourself in a place where you have no skill set to survive, meaning that you have nothing there that you can do to make a living. You're in a context where you're far away from your family. Your family are very unlikely to ever visit you there because it's so expensive to come and visit you. And so that's what you need to do when you have a large family. And or what you can do is that you could have somebody up in that northern region adopt your child and raise your child for you, and you could go back and you could continue on living your life. So these are the types of challenges that people face when it comes to socioeconomic disadvantage. And so you think, well, I wouldn't do that, I would move. And so if you look at First Nations Jordan's principle, which I won't go into detail because it's a whole other talk, you saw an example of a child that was in a hospital in Winnipeg, and the mother ended up moving to Winnipeg, and she actually died in Winnipeg. Her child died in Winnipeg too, and this was around jurisdictional issues between the federal and provincial government, who couldn't decide who would pay for that child to return back to Norway House. So our people, First Nations, Métis, and Inuit, are faced with a number of health challenges that are really, really tough. So ethical discourse, when we talk about bioethics and medical ethics, is a codified body of abstract knowledge held by experts about the good and the way to realize it. And we have whole departments of bioethicists and medical ethicists. But moral accounts, those accounts in which we talk to our families and make decisions, are in our local worlds, and what's at stake does not always fall within the parameters of biomedicine. So the moral is actualized not only in subjective space, but in social transactions over what locally matters. So what do you do when the people in your community say, no, you shouldn't let that child leave our land. You should not let that child have that transplant. Creator has said that that is the body that child is born into, and it should stay here with us, and it should live and die on our land. Versus your child will live, but it will live without you. It will live with somebody else. And so the conflicts among different priorities creates moral dilemmas as social problems that require action, and the social disparities are intersecting in that. And we, within the context of bioethics and medical ethics, we avoid local worlds in which patients and families struggle with decision-making related to their everyday circumstances. So I see many, many people, you know, and this is not a judgment in any way, you know, thinking about how can we help Indigenous people? What can we do? And it's really hard to, because the tyranny of geography alone is, what do you do? You know, what do you do when that patient needs, you know? So I think there are maybe many ways that we can look at things that could be done. But while transplant programs and the professionals involved with them have brief glimpses into the moral worlds of their patients and families, the scope of their professional practice leaves them woefully unequipped to be much of assistance in addressing the broader socioeconomic challenges faced by patients and families. And so once again, as I said, you can have the right biomedical, you know, outcomes. You can look at biomedical, and in the scoping review, they're looking at biomedical outcomes, but that doesn't necessarily mean that everything worked out. So what can we do? And I think, you know, when I looked at the presentation previously, I think that one of the things we can do is build a lived experience database, and not just one or two, but really, really look at building up a national database of lived experience, so that we can look at, you know, in the case of a clinical trial, that we can actually look at other factors and work with clinical trials alongside by building up a database of lived experience of patients, families, communities, frontline workers who are in the communities working with those patients. I think we need access to existing data. So the Canadian Institute for Health Information has data on Indigenous peoples. And we don't know what data they're collecting, but that's another way, is to make sure that we have access to all the data that is being collected and available to us. We need to take a rights-based approach. So that child that I spoke about held treaty right to health. I can bet my bottom dollar that none of you in this room know what that means. What are those rights? What does treaty right to health mean, and how does it apply in the context of transplant medicine? They have Indigenous rights. They have rights as a child. They have rights as a human being. What does that mean in the context of providing care? And I think we need to explore that more. And so that's where your professional organizations come into play, right? So you can't do it alone. You're busy doing the things that you do. You guys are stretched to the max, and this isn't, but you can do something collectively. And one of the things you can do is work with leaders, community leaders, not only Indigenous, but across different groups of people, in order to pass resolutions to say social determinants matter, social disparities matter. You can have media campaigns, and you can other forms of social action. So I always tell people, you can't be an Indigenous researcher no matter what you are if you're not an activist. And so I'm an activist. And so to mobilize change and have moral courage, it's really tough to do it one by one. It's really tough to do it in an academic publication, but collectively we can have conversations at meetings like this to band together to say, what do we do? Who are the politicians we need to talk to? What are the disparities that exist? And that's where that database would be very, very helpful. And we need expanding the lens of medical ethicists. We need to put pressure on bioethicists and medical ethicists to actually expand their lens beyond clinical and hospital settings by listening to the voices of patients, family, and broadening the ethical debate upon what does equal access mean. And so the last thing I'll say, and this is a study by Boaz, and they bring us to this question, which I would love to hear what you think as people who work in transplant medicine. And we do a lot of prevention in our communities. There's lots of funding, and you know, we try to do as much prevention around diabetes and other things like that. But they're really looking at, you know, more investment in primary health and prevention, meaning that let's prevent people from needing transplants in the first place, right? So we can't avoid it in all contexts, but let's look at raising social solidarity with the people who are implicated. So the social, cultural, and ethnic groups to increase organ donation. Thank you.
So I am going to introduce our next speaker, who is Dr. Sofia Ahmed, who will be presenting on sex and gender in pediatric transplantation. And Dr. Ahmed is a professor at the University of Alberta. She's a nephrologist and clinical scientist focused on sex and gender differences in cardiovascular and kidney physiology. Dr. Ahmed leads the Libin Institute Women's Cardiovascular Health Research Initiative and is a mentor to the next generation of researchers. Dr. Ahmed.
Great. Thank you very much for that kind introduction. And I'm truly honored to be part of this really exciting day. So thank you to the organizers for the invitation. I am an adult nephrologist, so any mistakes that I make are my own, and I would greatly welcome any corrections. So, but I do, I use the word inherit, but I do care for a lot of patients who have graduated from the pediatric population. So I'm here to talk to you about sex and gender in pediatric transplantation. And really, I don't have any, these are my disclosures. These are leadership positions that I hold, none of which pay. There's not a lot of money in sex and gender, but just they do inform how I see the world, how I do my work. I also want to highlight that I do aim to use person first and inclusive language, and there's things that I can do better. I will use the language used by the authors of the studies I'm citing, which is usually cisnormative and binary. And I do want to highlight that I come from Treaty 6 territory and have the pleasure of meeting Dr. Tait over Zoom recently, so it's exciting to be here in person. So over the next 20 minutes or so, we'll talk about the science and principles of sex and gender as they relate to transplant medicine. We'll talk about why researchers really should be including sex and gender into all aspects of their work, and that's been discussed already earlier today. And really, how can we incorporate sex and gender into transplant care? So this isn't just me or the organizers saying we should be doing this. So this was published in the New England Journal in the last month or so, October 1st. So I guess we're December now. And it talks about how, toward a biomedical research enterprise that better serves the United States. And I would argue when you read this, it's an excellent article. It's not just biomedical research, it's all four pillars of CIHR. It's not just the United States, it's really around the world. And they really talk about the role of research in centering health equity. And of course, there are many, many factors that go into centering health equity, but I just want to bring, given the topic of my talk, here they say much of biomedical research still does not account for biological differences between males and females, leading to differential success in treatments and outcomes. And this is, they talk about sex as a biological variable here, but I'm also talking about gender and sociocultural factors. And certainly I am not the first in any type of health research, and certainly many of our colleagues who are on this here in the fall of 2022 convened a global, I say controversies conference, but really consensus conference about incorporation of sex and gender in transplantation. And certainly a part of that was pediatrics, and I've only really the whole talk could be about this, but when they talk about there is one focus on the pediatric kidney transplant population, pediatric kidney transplantation population. And they suggest that there's a greater cardiovascular burden in girls compared to boys. So some examples, post-puberty, girls develop a higher blood pressure with higher cyclosporin trough levels. Girls with obesity have a higher prevalence of LVH, or left ventricular hypertrophy. girls have faster progression of arterial stiffness. So suggesting collectively that girls who get a kidney transplant have a greater cardiovascular burden. And just to build on what Dr. Preck was saying, like, what does this mean as these people age and become adults and live long and fulfilling lives? Well, it turns out that there is a differential sex and or gender differential in years of life lost in pediatric kidney transplant recipients. So this is Australia and New Zealand population data over 40 years. It's 30,000 plus years of follow-up. And not follow-up, cumulative, you know what I'm trying to say. 13 years of follow-up, but 30,000 years plus collectively. And basically they find that the majority of children with kidney failure do get a preemptive kidney transplant, but it's more likely that it's a male patient. The 18% of male patients get a preemptive living donation kidney transplant compared to only 10% of female children. Conversely, and perhaps not unexpectedly, there are more than 7 years of life years lost in female patients compared to male patients, just highlighting that there is, going back to that New England Journal article, there is differential success in terms of treatments and outcomes because we do have a one-size-fits-all approach. So this is an audience who's well aware that sex and gender are not interchangeable terms. Sex refers to biology. This would be anatomy, genetics, physiology, immunology. And when we use the terms male and female, we're referring to biological factors. When we talk about gender, we're talking about which has really nothing to do with biology, but certainly intersects with biology, is sociocultural roles. So masculine and feminine are the appropriate adjectives to use when we're talking about gender factors. And the social scientists in the audience are well aware, well ahead, I should say, of many of us who are in more biomedical research and have broken down gender into 4 things. These are more based on adult principles, but can be applied to the pediatric population as well. So gender roles. So for example, in the adult population, who is the primary earner in the house? Who is the person who is responsible for childcare? And you can think of the families who you see. Gender identity, does your inner sense of self align or not with what it says on your birth certificate? And so someone who is cisgender, that means that your gender identity is the same as what it says on the birth certificate. And if you are, and transgender is often used as an umbrella term for people who are agender, gender non-binary, agender, but basically it just means that your gender identity is not the same as your birth certificate, and that can change over a person's lifetime. Gender relations are how we interact with one another, depending on our own gender identity and the perceived gender of the person in front of us. So this, if you have a female patient in front of you, if you have a male patient in front of you, I should say a girl or a boy or an agender patient, or how they perceive you, this certainly does interact or influence our interactions. And lastly, institutionalized gender is the distribution of power and resources in society that disproportionately benefit or do not benefit people of particular genders. So this could be the wage gap. This could be whether contraception or access to reproductive health is available or not. This could be what type of washrooms you have in your institution. Are they single gender or is it all gender? And this, if it's not, these are things that you don't think about. You're probably part of a group where this particular institutionalized gender benefits you. If it's something that it affects you, you notice. So, you know, I talk about sex and gender, and they are certainly separate and distinct entities, but they definitely interact. And Dr. Gillian Einstein, who's a neuroscientist at the University of Toronto, talks about the world writes on the body. So we're born with a certain amount of, or certain type of biology, but what happens to us, our environment certainly does influence our presentation of disease and health. So let's start talking specifically about sex-related variables. So genetics, I mean, that's where it all starts. Here are a variety of high-profile publications over the last year in high-profile journals talking about genetics and kidney disease, transplant, et cetera. And so the majority of us, we're not talking about abnormal karyotypes today, are born with 22 autologous pairs of chromosomes and 1 pair of sex chromosomes. And as you can see, the X chromosome is considerably larger than the Y. It carries almost 5% of the human genome. But this is a bit of an older study now, it's 2013, but this is looking at genome-wide association studies, and how many of them actually included they say the sex chromosomes, but specifically the X chromosome. And at least as of then, only a third of these GWAS studies did. And there's a number of reasons why scientists say that they don't include the X chromosome. So one, they're only half the population has 2 X chromosomes and the other half has 1. So how do you compare those groups? Of the population who has 2 X chromosomes, there's mosaicism, meaning that there's random X inactivation throughout every cell in that organism's body. And then as an example of institutional gender, there were microchips for a long time that you couldn't actually even buy. They didn't even contain the X chromosome. So even if you wanted to include it, you couldn't. So I really like this editorial in Nature Medicine that the tagline is that basically just because something is hard doesn't mean that we shouldn't do it. It says that there are no shortcuts to good science. And I think we can all agree with that. So moving on to the immune response, there's definitely a sex bias in terms of the immune response. So on the x-axis here, we see the immune response all the way to the left is weak and all the way to the right is strong. And on the y-axis, we talk about how much host damage there is from low to high. So in a male organism, this is across species, in a male organism, in the context of an infectious exposure, there is a weak immune response. And so there's going to be a lot of host damage. Whereas a female organism with the same infectious exposure is going to have a much better outcome. Conversely, in the setting of an autoimmune disorder where we have a very strong immune response, this is disproportionately harmful to female organisms. And so we know this from our clinics, right? Like when we see, there are people here are certainly in nephrology, cardiology. I don't know if there's any rheumatologists in the group here, but you just know that every autoimmune disorder is more common in our female patients than our males, with the exception of type 1 diabetes, where there is a male preponderance. Sex hormones play a role in the immune system. So I am not an immunologist, but you can see that depending on whether an experiment or a study is done in the setting of testosterone versus whether it's done in the setting of estrogen, there's up or down regulation of different components of the immune system. And going back to type 1 diabetes, I want to show that preponderance of type 1 diabetes in male populations actually doesn't appear until after the age of puberty, so around 10 to 15. So you're really suggesting that sex hormones are playing an important role here. So evidence-based medicine has, I mean, I'm talking to mainly pediatric specialists in this room. So I'm talking about adult populations, and I know that like adult medicine is often extrapolated to pediatric populations. So you have a two-step here, but evidence-based medicine has historically been based on a male model, and I'm truly blanking on the time frame of these studies. But you can see when we look at all 4 pillars of research. So in cell-based research, most studies are male models, or they don't even report the sex. Animal-based models, 3/4 of them are male animals. When we look at human trials, 2/3 are men. I actually don't know about pediatric populations. And when we get to clinical care, at least in the adult population, that it's flips. And I'm exaggerating just to make a point, but it's almost like a clinical experiment. Because women are more likely to access medical care, and I'm using a cisnormative here, for sex-based reasons, contraception, pregnancy, menopause, as well as gender-based reasons. So there's actually been studies that have shown for a wide variety of health concerns, women are more likely to seek health attention than are men. And so it's almost like a clinical experiment when we prescribe a treatment or a therapy to a woman patient because she has not been represented in that pipeline getting that drug to market. And this is not just opinion. So this is the FDA. This is 20 years old now, but over a 4-year period, 10 drugs that were pulled from the market, 8 of them were pulled, and this is because of death or serious organ damage. 8 out of these 10 of these drugs pose more of a threat to women. And again, because of that lack of representation of getting that therapy to market. So those are a lot of sex-based reasons or variables in research, but how does gender impact transplantation outcomes? So gender roles are socialized from a very early age, and many of you might be looking at this going like, that is not how I was raised, or this is not how I'm raising my children. But it's important to recognize that, there are this is from the website is here, and like I pulled this up last week. So this is really important that our patients and our families, this is their gender roles. This is what they think is appropriate. And it changes across cultures. And so there's actually, these are the neuroscientists who are kind of ahead of us, at least in nephrology, thinking about, does gender change our biology? So from the moment of conception, when someone is pregnant and finds out the sex of their fetus, they'll start eating differently. They'll start being treated differently by their friends and family. And this could be a good thing or not a good thing. As soon as that child is born, depending on what it says on their birth certificate, we start treating that child differently, using different adjectives, dressing them differently, having different expectations. Dyeing one's hair, wearing makeup, painting one's nails are very gender-based decisions or choices. What we eat, I have a brother, and I remember us as teenagers in terms of, we'd open the fridge and there would be groceries and then there wouldn't be groceries. And I think everyone knows what I'm talking about. So, and it's impossible, the world writes in the body, right? Like, binge drinking, etc. This all impacts our biology. So just as an example of how both sex and gender can affect transplant outcomes, so many of our colleagues here, including Lorraine, so Lorraine, I'm going to get you up if there are any questions, please, over here. But really looking at medication adherence, this is Canadian data from the, I'm blanking on the acronym, but it's adherence in medication, positive. Thank you, positive. And it's 7 pediatric transplant centers across Canada, as well as 8 adult transplant centers across Canada who have young adults. And really, they were just looking at medication adherence by sex and organ type. It was heart, liver, and kidney in these populations. And they asked people at time 0, times 3 months, and times 6 months, as you can see on the x-axis here, and on the y-axis was proportion of adherence by self-report. So the question was, have you taken all your medications in the last 4 weeks? And as you can see, so I'm sorry for anybody here who has color blindness, but on the left is the female and on the right is the male population. And you can see that at all time points, female patients said that they were more likely to have not missed any of their medications. So that is one measure of adherence. Another measure of adherence that's commonly used in many trials is looking at the coefficient of variability. And this was looking at the TAC trough level. And you can see on the left is the female patients, on the right is the male patients, and the female patients have a much higher variability than to male patients, suggesting if we only looked at serum levels, that there was a lot less adherence in the female population. So which one is right? Well, I think probably what people said, but it just highlights that, the importance of at least stratifying by sex, let alone, and there were some great questions, age, menstrual cycle, were these people taking contraception? All of these things probably do affect metabolism, but we aren't taking those things into account when we're analyzing our data. So we live in a very binary world, and so there is increase here. These are adult nephrologists as well as a transplant nephrologist, Dr. Farouk. But just talking about, how we really in medicine really think of sex and gender. We conflate the two, and we also think of it as a binary variable. And this is a real problem when you think about someone who is not cisgender. And so this is an interview given to the BBC by my friend and colleague, Dr. Cam Whitley, who is a social scientist at the University of Western Washington and is a transgender man who lives with a kidney transplant. And he outlines, really as the first author in his own paper, about his challenges navigating the healthcare system as a transgender man who had kidney failure. Because when you think about just calculating eGFR, we include a sex or is it a gender variable. And depending which one we plunk in, we actually get quite different numbers. And this has implications for drug dosing, referral to nephrology, initiation of dialysis, exposure to contrast, etc. So just in the last few minutes of my talk, so how can we record gender identity, at least in our research, to then perhaps inform our care? So everyone here who lived in Canada in 2021 would have filled out the census. And for the first time ever, we had a two-step measure. Many of you will remember, and we were asked about our sex and gender. And I should mention, I've given us this, I've told my American colleagues and other international colleagues about this, and people are just flabbergasted. Like, there's no other word for it. That one, our Canadian government would actually collect this data, and two, that people would actually give this data to the government, because who knows what's going to happen to it. And that's a very real concern for people who are transgender, or because in some jurisdictions, it is truly a death sentence to come up, and that's including if for volunteering to be a participant in a research project. So people were asked, what sex were you assigned at birth? Meaning, what does it say in your birth certificate? And as you can see, the options were male or female. I think in the next iteration, they'll probably have intersex or prefer not to say. The question two, which best describes your current identity? Again, it says male or female. We know now that that is not appropriate. Those are sex-based terms. It really should have been man or woman. But what is really good is that they have the opportunity to self-identify. And if you remember nothing else from this talk, always allow people to prefer not to say or self-identify, and never have other. Nobody wants to click off other. This is true for gender. This also is, I think it's a great point, was brought up race. No one wants to click off, I'm an other race. So what are the results? So as I said, we are the only country that collects this. So as you can see, the vast majority of the population identified as cisgender men or cisgender women. That's the green and the blue and the big circle there. But that purple slice is people who identified as transgender and non-binary, and 0.33% of the population. And it's roughly a third transgender men, transgender women, and non-binary individuals. But what's really interesting and relevant for this group is 2/3 of the respondents were under the age of 35. And another way of saying that is that 1 in 300 people over the age of 15 in Canada identify as trans or non-binary. And this is, again, I'm speaking to my pediatric colleagues here. These are referrals in Canada to 9 clinics, major clinics across the country. And you can see on the x-axis here is the year in which they're just counting referrals to specialist clinics specifically for puberty blockers or gender affirming hormone therapy. So these are not questioning kids. These are kids who are being referred for hormone therapy. So in 2004, you can see, you could count on one hand how many referrals there were. And now when we look at 2016, and I have no doubt that this has exploded since then, it's really increased. So it is something that we do as healthcare professionals need to incorporate into our research and our work. And so in the US, the National Academies of Science and Engineering and Medicine actually commissioned a report on the best ways to measure sex, gender identity, and sexual orientation, which is another topic that's for another talk. So the bottom line is every cell has a sex and every person is gendered. And so when we design our research, when we approach our clinical care, these are important factors to remember. So with that, I would be very happy to take any questions and just acknowledge my lab and my funders. So thank you.
Thank you so much. And I'm sorry I didn't get your updated bio in time. So I think Dr. Lori West will be moderating the Q&A since she's there in person.
Thanks, Aviva, and congratulations on your son's basketball success. That prevented you from being here. Oh, volleyball? Oh, sorry, that too.
All good.
So those were really both very interesting talks. Do we have questions from the floor or from the chats? Maybe I could just start by asking Sofia, I think, do you want to come back here?
Yeah.
How are we talking to here though? Is it just this one?
I think so.
Yeah. You know, when we had the consensus conference that you mentioned in in Hanover a few years ago, one of the interesting questions or comments that came up from an international audience was the difference between sex and gender that we are more and more clearly understanding in English doesn't always translate into other languages, and yet the concepts do clearly. Do you find that in the reading and the studies that you've been citing here, a way to approach that?
Absolutely. So thank you for that question. So it's important to acknowledge, and I should have said this up front, it is quite a Western concept, this separation of sex and gender, which of course intertwine as well. And as Dr. West aptly said, like there are many languages that there's just no differentiation between the two. So for example, the European Union in their Horizons 2020, they talk about the gender dimension because it doesn't translate well in other languages. And the other thing I just want to highlight is it's not just a language thing, but it's also a way of approaching. So, and Dr. Tait, you can certainly add to this conversation, but so, you know, this idea that there's only two genders is also very Western. So when we look at, you know, I talk to my Indigenous colleagues and Indigenous scholars, and in many Indigenous cultures, there's, for example, like 7 genders. And it's just so it's a very Western concept. And so there's a lot that we can learn from talking from people around the world and different cultures about just how we think about this.
Increasing complexity. Caroline, would you come up as well? Maybe we could ask you to comment on that same concept, and then I think David has a question, please.
Thanks. I don't have much to add on that, but yes, definitely. I think I mean a couple things. One is that in our culture, two-spirited. I mean this people across kind of First Nations, Métis. I don't know Inuit as well. Definitely, gender is something that the Western concepts of gender don't really fit in the way that we think. However, the impact of colonization and the impact of Christianity has certainly shaped those ideas in ways that that create all kinds of challenges in our communities, including people, you know, some of our communities not being particularly safe for people who are gender fluid or who you know, express anything apart from being either male or female. So it is quite challenging for many of our people. Yeah.
David?
Thank you for these great talks. Just wanted to ask Dr. Tait, your comment around the challenges in northern and remote communities in terms of access to care. Can you comment on the role of technology and virtual care to bridge that or address some of those issues?
Yeah, thanks, David. So I work with Dr. Ivor Mendez, who works a lot in robotics and digital health, remote presence technology. And we had actually with Dr. Bello last week and Dr. Hughes from Australia, that both Australia and Canada, the use of technology may be able to help reduce times, the amount of time that a person has to travel, right? So geography is such an enormous problem. And if you have ever been on northern roads, you'll know that getting across northern roads, and even climate change has had this impact where in the wintertime, the winter roads don't exist. And so you have to rely on flying in and out, and it can be really, really difficult. Where the remote presence technologies in Saskatchewan, we've had different applications of them for quite a while, like probably about a decade now or more. And we also have a training center being built at Whitecap Dakota First Nations to train people who are Indigenous to be technicians and use the remote presence technology. So I think there's a lot of potential for anyone who wants to do some research to look at how the application of those technologies, and we could partner definitely with Whitecap Dakota and with Dr. Mendez and the team that we have. Yeah.
Thank you. I think Aviva has a question.
Yeah, thank you both for really excellent presentations. And as I was listening to you, I could think of patients in my own practice that would fit into both of the situations you're discussing. Dr. Ahmed, for just very practical question, I have a number of kids who are exploring their gender identity in my practice now. And one of the things I'm struggling with is what ABPM parameters to use for them, like which blood pressure parameters to use. Do I change them? Does it matter if they are on puberty blockers and hormones? And what do I actually do? And parents are asking these questions, and I honestly don't know what the right answer is.
The short answer is I don't know what the right answer is either. But it is interesting because there is, at least in the adult population, so there's a few things. There's a tendency for all of us to sort of think transgender and immediately go to what is the impact of hormone therapy. And we actually have a study that's under review that suggests, at least in trans feminine individuals taking gender affirming estrogen therapy, that blood pressure is similar to cisgender women not on hormone therapy rather than cisgender men. Take that with what you will. And there also is increasing, there's a lot of I mean, we know this, right? Like outside stress certainly does impact blood pressure, gender minority stress, socioeconomic factors, etc. And so people who are in the transgender community are disproportionately affected by those factors. And there actually is some data that suggests that once people start taking hormone therapy, or at least living who they feel they really are, that actually takes some of that stress away and their blood pressure goes down. So that was a long answer and a non-answer to your question, but I think it really highlights that we do need research in this area. And in order to do that research, we need to actually collect the data. And I do want to highlight, or there was a comment earlier about these are, childhood transplantation is not a common scenario. And I do acknowledge that these are not big studies or not big trials, but if at least things could be stratified or described in table 1, then that does give us the possibility to do systematic reviews, meta-analyses, and at least come up with some potential answers to these very common clinical questions that you bring up. So thanks very much.
Thank you.
Rulan? Oh, I'm sorry. There's just one question, Saida over here, and then Rulan.
Yeah, I just have a question for Dr. Tait, for the presentation. I just had it with my company to know, what do you think is like a best approach? Like, I guess this is from the government kind of responsibility to make this struggle for the families that live in these remote areas. Especially, I think in the first year, probably post-transplant, there's lots of monitoring, but like logistic-wise, like first, like how government can help, and second, like what families want, that because there's lots of staff, I would think they would be going there for the monitoring, and there's lab, there's samples that can be tested. So I'm just curious to what do you think should be done?
So my short answer is I'm not exactly sure. And the reason is one of the things, and some of you have heard me talk about this, is the lack of attention by our Indigenous health leaders to this very question, right? And the reason why there's a lack of attention by the First Nations, Métis, and Inuit health leaders is because they are so preoccupied with the opioid crisis. They're preoccupied with housing insecurity, food insecurity, all of which factor into exactly the question you're talking about. So you have post-transplant, what happens when you don't have access to good food and you're unable to maintain the type of diet that you may need to maintain for you or your child. And so we have one of the things that did happen in 2024 is that the BC Chiefs passed a resolution making organ donation and transplantation a health priority for the BC Chiefs. So we wrote a resolution after our Cafe Scientific in February. We presented it. I presented it to Chief Philip, who's a double transplant recipient, and it was passed unanimously. So then I go to them and I'm like, okay, let's take it to the Assembly of First Nations here we have this big project grant with CDTRP and some of you in the room looking at all of these types of issues. And the message back was, Caroline, we're too busy. We're just too busy to even push this forward right now. So our communities, and including in the far north, we're at war with organized crime. We are at war with the amount of drugs coming into our communities, the ways our young people are being used, and it's really a preoccupation that I have not seen to the degree that I see now. So I think I turn back, you know, in terms of, I think we just need to keep talking and pushing and trying to get the attention of the Indigenous leaders, and then trying to push forward with government as much as we can. One of the things I'll just say lastly is that all of you can do is recruit Indigenous students, you know, and whether that starts going into high schools and capturing the imagination of our young people are smart, and we have this growing middle class of young Indigenous people, but they don't always know, we don't always know the pathway. So we go to become a teacher, we go to become a lawyer, but we don't think of clinical science as an actual pathway to a really good job. And so, as crazy as that sounds, sometimes we need to start, you know, by looking at the capacity that we need to support our you know, people in. But it's a tough question, and I don't have good answers, you know. So yeah, thank you.
Very complex, isn't it? And last question, Roland?
Yeah, I was wondering whether we should think about when we're asking questions about, let's say, it's struck me the CKD equations for kidney function and how we made a radical change in eliminating race because it's a physiological test. And so should we, rather than saying sex, should we start saying biological sex and sort of change the language by sort of having that inference each time? And maybe that's the way to conceptualize it so that we can then sort of spread and scale it. And, you know, people to think about it, and it's more subtle than just, you know, talking about the differences between sex and gender in some ways. I just wondering.
No, that's a great question. And also that's my pager going off in case anybody. So I will get to it. And if you want to just press it, anyway, don't worry about it. How embarrassing is that? Anyway, great question, Roland. So I think the most important thing is that we actually at least collect what we're or be accurate in what we're collecting. We actually did a study, and these are again in adults who are on gender affirming hormone therapy, where we did directly measured iohexol and compared it to 7 different commonly used equations. And bottom line is, whether you put in sex, whether you put in gender, it didn't really change. It's not a great. So I guess the first thing I would say is let's at least start accurately. Are we collecting sex assigned at birth? Are we collecting gender identity? And we should probably collect, not should, we collect both. And then the second thing is, in the absence of data, and this goes back to Dr. Goldberg's question earlier, at least having that discussion, like more of a holistic approach with our patients, right? Like, you know, this is the data we have. This is your scenario. You're on hormones, you're not on hormones, you're, you know, this is your social situation. And this is, let's make a decision together based on the best available evidence, which hopefully this time next year we'll have more. But great question, so thank you.
So thank you very much again for these incredibly complicated, right in front of you, these descriptions and work in these very complex areas, both of them. But it is an exciting time to be, like, we're actually talking about these things now on a regular basis at research meetings such as this. So please join me in thanking Dr. Ahmed and Dr. Tait for these wonderful presentations.